A lot of evidence has always required in terms of health planning. So any informed health policy decision always requires data. And our previous speaker, Yamini and Dr. Ila also presented the same thing, that you need a lot of data, but we don't have those kind of data at a national level. So the same was actually put forth by many other researchers in the past. So Michelson actually reported that India fared as low as less than 0.25 as regards the vital statistic performance index globally that was undertaken. Similarly, there was another study which reported the same thing. So the objective of our paper today is to undertake a detailed analysis on the different sources of information in India. What are the kind of quality and availability of such data, and we have picked up AP as a specific case study. Why we picked up AP was AP is one of the best states in the country which is quite tech savvy, and therefore has adopted a lot of mobile based technology to enhance its data quality. So we felt that anything that is done well in AP is probably the benchmark for can be a benchmark for most of our states, and if it is not happening there, then probably we can say that, safely say that these data gaps do exist in other states as well. So with that we took up this study. The national data has been primarily on a secondary research on the existing data and the resources and the research studies. If you see in India, we have had a lot of studies around data deficiency in India, but none of the studies have comprehensively looked at the entire data from the national to the subnational to institutional and individual level. That is where we felt that we can undertake a detailed analysis and speak about the challenges that are there. So if you look at the international experience, Dr. Brian talked about the framework in which the Australian government works. So that's the health management network that WHO had put forth. And most of the countries have signed off on that and have a very nationalized, strong program in terms of strong foundation in terms of their databases, which cuts across all the other databases both horizontally and vertically. Very well defined electronic health record management system most of the countries have, which is linked with unique ID numbers, and therefore have very strong decentralized data management system at a subnational level, and you have a lot of data linkages across different sources of data, whether it is the pension funds or it is the service taxes or any other related departments, all do get interlinked. So internationally that kind of a strength does exist in terms of data and its management system. Also there is a very strongly defined legal framework which actually ensures the personal privacy of data when it is being used for various kind of population based researches across the platform when you are doing a lot of population based research. So this is the WHO framework of 100 core indicators. India has also signed off on these sustainable development goals. It actually says that there are certain input indicators, service indicators, and there are certain output and outcome indicators. One of the indicators on behavioral change Dr. Brian had shown in his slides. So those are the ways to look at each of the parameter can be looked in the same fashion, and it has certain impact indicators. So every set of indicator that are there, whether they are risk factors to health or they are health specific or sensitive indicators, can actually fall within this framework and can be evaluated. So most of the OECD countries today adopt these 100 core indicators. That is what when we undertook the research, international research, and we found that these are the strengths that are there with these countries which have adopted the international framework. So when we looked at our data sources in India, there are two sets of data sources that India has. One is the survey data and the other is the administrative database. So these are all the survey data that we have. Some of them are done by the Registrar General of India, and some of them are done by the Ministry of Health themselves. Some of it is done by the Ministry of Statistics. You have got similarly administrative data like CRS, HMIS, concurrent monitoring, National Health Profile, Integrated Disease Surveillance Program. So these are all some of the administrative data that flows across. So IDSP, sorry, it actually is a survey, so that the Ministry of Health undertakes. So, but when we looked at the challenges, if you actually see, the challenges are at different levels, as we said. At a national level, there is a strong governance and leadership challenges. There are different sources and you have got divergent figures. As Yamini in her presentation also brought out very clearly, that there are multiple sources from where the data gets generated, and therefore they all report differently. One of the studies of HMIS and the coverage immunization survey that was undertaken for immunization reported that there was a 20-point variation between the child immunization for measles in the reported live births in the year 2010. Similarly, when we looked at the AP government itself reports that there are 80% of the households have got access to drinking water, and 60% of them have got access, 40% of them have got access to toilet, but the NSSO and the CES data shows that around 35% of them have access to drinking water and only 21% of them have an access to toilet. So there's a huge discrepancy between the data sources that are there. And similarly, if you actually look at the nationalized governance mechanisms, when we see the procurement of various nationalized information system like the HRIS, the Government of India started a health resource information system, but the procurement was, while the guideline was centrally planned out, the procurement was decentralized, because of which what has happened is every state has procured this software at different levels. Some of them have it at a on Java platform, some of them have it on an open platform. All of them are using it for their own personal needs. So what is happening is there is no national level integration. Say for example, in AP state, they have gone ahead in 2007, it provides for online counseling and training, but there is no national link to this database. So you actually cannot utilize this database for a national level research. Similarly, if you look at the linkages between data sources, one of the studies undertaken by Ackerson very clearly points out that there is a very strong linkage between domestic violence and anemia and undernutrition in babies. But if we were to do such a kind of an analysis in India, it is very difficult for us to do that kind of analysis, because the crime reporting which is undertaken by NCRB, the National Committee for National Crimes Reporting Bureau, and that of the data which is produced by WCD, that is Women and Child Development Department, on the Nutritional Monitoring Bureau that they produce data, you cannot have any linkage between these data because they are handled by different ministries. There is no formal engagement which says that how can I pull the data from these sources and make a defined analysis which can actually draw those kind of linkages, which internationally people have done studies on. Similarly, if you look at the data dissemination issues, we have as a country, we have significantly fallen short in terms of data dissemination and utilization. The 19 core health indicators that India is supposed to give as a part of the global burden of disease evaluation by WHO and the 12th 5-year plan data, we still now have not given our data for 2008, so it's already 2016. So we lag behind so much in terms of our ability to share data at an international level, which can be used for evaluation, like Ila in her presentation pointed out. We still have that WHO's data, but our data has not gone to them so that they can make an effective analysis of actually understanding the burden of disease in the country. So similarly, if you look at the vital statistics from different sources, so this is basically the CRS and the SRS. If you look at the data, the birth rate, it varies between both of the data sources. The sex ratios varies during the same period if you actually see. So why are these challenges which are there? If I look at the national level and go down to the subnational level, even at subnational level, there is a serious lack of data from private sector. We heard from Rachna's presentation that 70% of our population accesses the private health sector, but none of our data that we capture today has any access to the private sector data. So we severely lack private sector data. The CES and the NSSO morbidity and mortality survey of 2009, both the reports have clearly indicated that there is a serious lack. And the other way that we are strongly limited are in terms of, in terms of disaggregated data availability. We don't have data available in terms of vulnerability of the sections and the population. We hardly generate that level of subnational data in the country, except for very program specific or donor funded projects where we collect those kind of data. In a regular fashion, we don't collect those kind of data, neither do we report on those kind of data. When you look at the probing skills also at an institutional level, there is a huge difference between the probing skills. The same morbidity and mortality survey which was undertaken in 2009 by both NSSO and coverage evaluation survey, on the same probing, they had different set of answers which was available to people. Similarly, if you look at the institutional level, there is a serious shortage of staff. The 30% of nursing positions in the rural health survey was filled, and around 1 ANM was taking care of close to 5 villages. So she also looks at the operations and she also does all the data compilation. So you can imagine the level of incentive that she must be having to collect data and report. So again, when you go down further at the institutional level, there are serious methodical issues in which the data gets reported. If you look at the CRS data, the date of registration of birth, some states take date of registration of birth as a data. Some states take date on which a birth has occurred. So there is a two different way of reporting the same data of birth rate. So you actually cannot know that how one of the states has collected the data. So there is a methodical issue in which we are collecting data. There is a serious issue in terms of the data triangulation. The cause of death we are not able to evaluate across sources because the CRS data and the SRS data, the baseline of the national level death rate do not match. So it is very difficult to triangulate data across sources. And in certain cases, we also do not have baseline data. Say for example, the government was supposed to table the review of health outcomes of the 11th 5-year plan. So the NRHM with its framework of 2013 wanted to do an outcome study, and the birth rate and the death rate between the states differed across sources close to 50% to 100%. So it was very difficult for them to establish a baseline on which they could report on these data. Similarly, some of these surveys are evolving on their own. Say for example, if you look at the NSSO survey, from the 60th round to 71st round, the survey itself has evolved. So the way the data used to get captured earlier and today, it is non-comparable. So say for example, definition of household has changed. Earlier we never used to include students residing in hostels irrespective of their periods of absence. Any woman undergone childbirth in last 1 year and has incurred some cost irrespective of her place of residence is also included today. Any child less than 1 year is a member of the household, which was not there earlier. So if you look at the various rounds also, we are actually evolving. What I am trying to say is that the data management system in the country is evolving. So these are some more data points from the 60th and 71st round of NSSO. What are the differences? So if you go down further, there is a, if we look at, we went further down to look at AP as a state. I'll just skip the earlier slide. So AP also has the same mechanism of data collection like at a national level. You have got a state health department and you have got sub departments under it, which report on various areas like medical education, the various state and national level program, family welfare, and there is a separate commissioner for Andhra Pradesh, Vaidya Vidhana Pradeshad, because they have a separate insurance scheme. So say they have a separate director to look into that. So the system of data collection is the same like at a national level. But when you look at the data, the way there is a discrepancy, if you look at Andhra, so the BCG given should be less than equal to the number of deliveries. So we looked at 14-15 and 15-16 data. So there is a huge difference. The number of infants who have received BCG is much more than the total number of reported deliveries. Similarly, if you look at the second row, the BCG given should always be less than the number of live births, less than or equal to. There also you have got 124% discrepancy in both the years. So in the third year again, third row, if you see, the total number of deliveries should actually be equal to the number of live births and stillbirths. But if you actually see the data, the number of live births and stillbirths put together are more than 133%, 106% both in these 2 years. Similarly, if you look at the number of complicated pregnancy that are treated with IV antibiotic, should be less than the total number of complicated pregnant women who had some kind of an obstetric complication. But if you actually see that the ratio is more than 240%. Similarly, if you look at the number of complicated pregnancy treated with IV oxytocin, they should be less than or equal to the number of women with obstetric complication. They are also way high, 307% and 144%. So again, if you look at, so this is the internal inconsistency of data. If you look at the external validation, when we undertook a few of the data points, the IMR in SRS and CRS and NFHS, if you see there is a huge difference, 39 and 35. Similarly, if you look at the birth and death rate, both for 2013 of SRS and 2014 of SRS and CRS are quite different. Similarly, you look at the sex ratios, there is a huge discrepancy between the various data sources. These are the vital statistics where we are falling severely short. Similarly, when we go further down and look at the difference between the government's own administrative information management system, that is the HMIS. HMIS is the only administrative mechanism which is a web enabled data management system where the people can directly from the states upload a set of data which can be pulled up at a national level and people can undertake analysis on them. So if you look at that with the NFHS survey, there is a huge discrepancy between the data during the same period. So institutional delivery of total reported deliveries, if you see 96% and 98% and 91%. Percentage of delivered by cesarean section 40%, 33%. Births in private health facility delivered by cesarean section 57%, 22%. So if you look at each data point, you would realize that there is a huge discrepancy between the data sources. We undertook external validation also for the facility level information. So these are the information that gets generated from the facility, like the hospitals themselves report on this data. So when we compared the DLHS-4 and RHS, you would see that the huge discrepancy in terms of the number of PHCs and CHCs that is being reported by two different sources of the state itself. So the total number of subcenter is 468 and 12,000, huge discrepancy in data. We also undertook an external validation of the workforce. There also we saw that there is a huge discrepancy between the PHCs having medical officers, lady medical officers. We also went slightly outside the modern medicine. We thought that maybe in Ayush they report better. In Ayush also they are reporting very badly. So what I am trying to say here is that we have a huge data problem, and this is one of the states which is actually tech savvy and one of the better performing states. And there, if we have this level of data challenge at each level, whether we talk about the workforce, the facility level information, various data that we cover for population surveys, various data in our administrative system itself, we can imagine the kind of data that we get from the economically supported states which are there, the EAG states that are there. So what is the conclusion and way forward for us? So I think Ila had concluded very beautifully for me. So I think I would like to put that as one liner, that what we need is to mainstream the risk reduction across the country through a nationalized, integrated disease surveillance and decision support making system, which has to be an overall database. If you actually look at all these data sources that we picked up, all these data sources were PDF files or individual Excel sheets which we had to pull down separately, collate them and undertaken research around it. There is no way that you can pull and push data into the mainstream. So it is very difficult to undertake a nationalized or population based research if we don't have a national HIS infrastructure with a good regulatory framework to ensure data privacy, and an integrated system to draw correlation across departments, whether it is women and child, water sanitation, public works and engineering, and health. And health department can only give analysis and correlations of these, that how health sensitive data impact health and what are the kind of risks that are there. They obviously cannot go and do there something, but we need an integrated system and a standardized definition like the OECD countries have done. They have taken the international standard definitions of various data points. We should look at using those kind of standard definitions and improve our data quality and availability by looking at those kind of definitions, and monitor and evaluate and communicate results to the facility level. What happens typically is, when we collect data, when the data is pushed to the state level, hardly there is any communication back to them saying that, you know, there were these discrepancy, you should look at this. So unless and until you tell the people that these are the ways where you have found data gaps, there is no incentive. For them it is at end of the month reporting on certain Excel sheet and be done with it. So with the shortage of staff, they do as much as they can, sit down at the last day of the month, fill the data and push it. So there has to be a lot of capacity building therefore to the staff to incentivize quality and data. So this is the WHO framework which globally we use, and if it sits on an integrated data management system which can pull and push data at a national level with a well defined security and bridge to enable data integration, I think we will be one of the best ways to look at our data and support our evidence. Thank you.